My name is John Stride, and I'm the current president of City Club of Portland. We're delighted to welcome all of you to our monthly City Club Friday Forum. This program and next month's Friday Forum are a collaboration with the Oregon Health Forum. It is my honor and an honor for City Club and the Oregon Health Forum to be joined by former Governor John Kitzhaber and Dr. Bruce Goldberg this afternoon. Thank you. Before we begin, take a moment to silence your cell phones, please. Thank you. And now just a short word about City Club. Our mission is to inform our members and the community in public matters through producing nonpartisan public forums, debates, and research that inform our members and the community about elections and public policy. City Club is committed to providing a space for civic dialogue that encourages respectful discussions and positive change. City Club members are the ones who provide the ideas, lead our conversations, conduct our research, and plan programs such as this that address issues important to our community and the state. Member dues and donations make it possible for City Club to provide these kinds of programs for free to the public. Upcoming events include 3 more evening forums with Portland City Councilors like the one we had just 2 nights ago in District 3, in which councilors meet with their districts to discuss this first year in office and the new and unique form of city government in which they're working. Our moderator for these programs will be Sophie Peel of the Willamette Week for each forum. In exactly 1 month from today, the City Club will present the second Friday Forum dedicated to healthcare. Our panel will discuss how to translate the healthcare options discussed today, along with their own proposals and how that is put into real-life practice. Our panelists then will be Rachel Prusak, the Executive Director of Oregon State Board of Nursing, Jack Friedman, the Chair of Pacific Source Health Plans, and Dr. Tony Gurman, a prominent rural family medicine physician in Oregon. Bill Kramer of the Oregon Health Policy Board will moderate that discussion. Everyone is welcome at City Club. We particularly welcome those folks who care about our region and want to make a difference in it. You can learn more about our events at membership and research at our website, pdxcityclub.org. And if you join today, you can take $40 off your annual membership dues by using the discount code NEW40, that's N-E-W 40. And if City Club dues are a barrier to membership, we have a dues assistance program available for you. These events are made possible by our sponsors, and a special thanks to our season sponsors, AARP Oregon, Fight Against Sex Trafficking, Hospital Association of Oregon, Tonkin Torp, and the Don Sterling Fund at the Oregon Community Foundation. We also want to thank the Oregon Health Forum's annual sponsors, the Hetherington Foundation for Innovation and Education in Healthcare, and Care Oregon. And lastly, we thank today's sponsors, Baker Tilly and the Oregon Physicians for a National Health Program. Please join me in showing our appreciation for their generosity. And finally, a quick shout out to the producers of today's program, our City Club Program Committee members, Sam Metz and Shoshana Baird. And as always, we thank our Communications Director, Kayla Kennett, for her support. Now, I would like to ask Kim Crosby, Director of Operations of Oregon Health Forum, to say a few words about OHF.
Excellent. Thank you so much. Thank you for the introduction, John, and for the opportunity to partner with the City Club of Portland for both this event and the March event coming up. Oregon Health Forum is a nonprofit organization committed to advancing health policy solutions through meaningful community dialogue. We present monthly events, both in person and virtual. For more information about upcoming programming, or to view our past programming for free, please visit our website at OregonHealthForum.org and follow us on social media. We are an affiliate of the Lund Report, Oregon's only independent news source dedicated to healthcare coverage. Please consider subscribing on our website, thelundreport.org. By subscribing, you are supporting transparency and accountability in healthcare news. We also have a table at the venue's entryway with more information and a newsletter sign-up form. Please stop by and say hello to us to learn more. Now I will hand it back to John to kick off our discussion. Thank you.
Thank you, Kim. Doctors Goldberg and Kitzhaber have both long experience with Oregon's healthcare policy. As Senate President and then Governor, Dr. Kitzhaber initiated Oregon's unique tiered benefit program for our Medicaid program. He later introduced Oregon's coordinated care organizations as a method for administrating Medicaid. Dr. Kitzhaber now serves as CEO of the Foundation for Medical Excellence. Dr. Goldberg was the founding executive director of the Oregon Health Authority, which oversees the state's public health program, the Oregon Health Plan, our behavioral health services, the Oregon State Hospital, and the licensing of healthcare providers. Dr. Goldberg is currently a professor at OHSU's School of Public Health. Today they will discuss how recent federal legislation, rising costs, and unstable financing threaten healthcare access for all Oregonians, including threats to Medicaid, employer-sponsored insurance, and to marketplace insurance. We look forward to hearing their thoughts on both short-term and long-term answers that will protect healthcare access for Oregonians. We're grateful to have these distinguished leaders join us today, but please be aware that both our guests represent only themselves at this forum and do not represent official opinions of any organizations of which they may be a member. Following their discussion, Drs. Goldberg and Kitzhaber will provide significant opportunity for audience questions. So we invite you to consider questions as they give their presentation and be prepared to ask those at the conclusion of their remarks. During the question and answer period, questioners will be asked to line up on this side at a microphone and keep your question to 30 seconds or less. And we ask you to actually make it a question with a question mark at the end. Okay, thank you. And now, Drs. Kitzhaber and Goldberg, please join us.
These on?
Check. Wow. Okay.
Kitzhaber and Goldberg sounds like a law firm.
Have you had an injury lately?
Well, thanks very much for having us. We're just going to take a couple minutes at the beginning here and kind of set a little context. As you know, for the last 30 years, Oregon has been at the forefront of national health policy innovation, driven consistently by the goal of better health, better care, and at a lower cost. That work has been animated, I think, by a willingness and the courage to challenge the underlying assumptions and structures of the current healthcare system, which I think is even more important now than it was maybe a few years ago. Over the last 50 years, health policy in this country is focused primarily on expanding access using public dollars. And the way we've done that, the major programs were Medicare and Medicaid in '65, the Children's Health Plan in 1997, and then the Affordable Care Act in 2010. So what we've done is we've used public dollars to make healthcare less expensive for individuals, which is a good thing, but it's not the same as reducing the total cost of care. As a result, we have seen an increase in healthcare costs of over 10,000%, from $150 per person in 1965 to about $15,000 today. That makes healthcare literally unaffordable, increasingly unaffordable for individuals, for businesses, and for employers. As we're going to discuss today, the healthcare system depends largely on and increasingly on public resources. And as the constraints on public resources grow, the underpinnings of the healthcare system are starting to fall apart, creating a crisis in cost, but also a crisis in access. And at the intersection, as Bruce will talk about in a moment, the passage of House Resolution 1 last July is expected to take about $8 billion out of our healthcare system here in Oregon over the next 3 biennia. So the intersection of escalating costs and declining federal resources has brought our system to an inflection point. But in my view, it also offers us a tremendous opportunity. No more money is going to magically appear to bail us out here. As I will talk about later, more money through the current system is actually not going to improve access, nor is it going to provide the long-term stability that hospitals and doctors and insurers are looking for, right? But it gives us the opportunity in this state to do what we've done so many times before, and that is come together as Oregonians and have an honest identification of those parties and factors that are driving medical inflation and develop a shared long-term strategy to move us through this crisis to a system that ensures that all of us have access to quality, affordable health care in a system that's equitable, sustainable, and financially viable.
So I'll sum that up by saying a crisis is a terrible thing to waste. And hopefully we can talk about that. But today's a real opportunity to talk about the current crisis, what it is, how it affects all of us, and what we can do about it. Healthcare has become increasingly complex. I think, as everybody in here knows, if you've ever tried to understand the explanation of benefits that you get, it's impossible. Your healthcare bill is impossible to understand. It's really difficult to get care in our healthcare system. And for those of us who provide care, it's really difficult to provide care. It's become incredibly complex. So, our pledge to you today is to actually try and have a plain language conversation about this. We're going to try and avoid health policy speak and talk plainly. So let me start by talking about the current crisis. Well, it's not a current crisis. We've had a smoldering chronic crisis of our healthcare system for decades. As I indicated, it's way too complex. As Governor Kitzhaber just said, it's way too costly. Too many of us can't get the care that we need. And now, on top of that, we have H.R. 1, the big, beautiful bill, although I know a number of you have other names for it. But let's talk for a minute about what that does. H.R. 1, huge piece of federal legislation passed this summer, really impacts just about every aspect of life. It impacts health and human services, it impacts taxation, defense spending, student loans, you name it. It's quite expansive. Today, we'll talk about what it does for Medicaid into our state. And indeed, it really creates tremendous difficulties for us to continue to deliver health care to our most vulnerable populations. Let's start with Medicaid. And just to level set, Medicaid is, also here in Oregon known as the Oregon Health Plan. Currently, the Medicaid program covers 1.4 million Oregonians. That's 1 in 3 of us get health coverage through the Oregon Health Plan. 57% of all kids in the state are on the Oregon Health Plan. Half of all deliveries. Pretty substantive group of all of us. What H.R. 1, and this is a federal-state partnership. So the feds, interestingly enough, pay 60% of the bill, and we as a state pay about 40%. That makes them the majority partner. And although we call it the Oregon Health Plan, they set the rules and the funding. And indeed, it's the rules and the funding that are going to create tremendous difficulties for us. And let me walk through that really quickly. On the rule side, what H.R. 1 does is it requires 600,000 low-income adults who are currently on the Oregon Health Plan to document that they have 80 hours of employment or community engagement in a month. Community engagement defined as job seeking, job training, certain improved volunteer activities. So what's that going to mean? Well, first off, it means we're going to have to invest as a state a lot of dollars in an already strained state budget to be able to track all of that. But more importantly, it means about 200,000 individuals are going to lose health care coverage. Why? They're going to make an error on a form. They're going to move and lose something in the mail. They're going to be late in handing something in. They may not be able to find a job and won't meet some of the criteria. And all of those individuals are still going to have health care needs. And now they're going to become the rank of the uninsured. We had been close to 97% of our state having health coverage. Now we're going to dip down. We're going to have 200,000 people who are going to lose health care coverage but still have health care needs. They're going to still end up in doctors' and hospitals' offices and unable to pay, and those costs will be shifted to all of us. Then we have the funding side, which is enormous. H.R. 1 cuts about 14%, $900 billion out of the federal Medicaid budget over the next 10 years. Here in Oregon, the effects are really, really sobering. We are going to lose about $200 million of federal funds over this current biennium. We're going to lose $3.3 billion with a B over the next biennium, 27-29, and we're going to lose $4.7 billion with a B of federal dollars into our state's healthcare system in 29-31. Why is that? Well, Oregon, like most other states, uses a variety of administrative mechanisms to fund the Oregon Health Plan. We use provider taxes, intergovernment transfers, state-directed payments. Don't ask me to explain those. There isn't enough coffee in the room to keep you awake during some explanation of those. But let me tell you, what it really does is it just ratchets down every year the ability of states to use those mechanisms. You don't need to understand the mechanism, you just need to understand the financial impact, which is huge. Over $8 billion over the next 5-6 years. And that's going to cripple our healthcare system. And the more important thing is it's going to affect individuals. Let me turn it over to Governor Kitzhaber to talk about how those changes are going to ripple through our state.
Yeah, thanks, Bruce. So as Bruce just discussed, H.R. 1 has precipitated a crisis, but our healthcare system is on a financially unsustainable trajectory long before the passage of that legislation. So the point is, this is not just a Medicaid problem, it is a system problem. And it's going to impact everyone in this state, whether you're on Medicaid or Medicare or having a good commercial policy. So the point is, this is everyone's problem, and the only way we can solve this is if we work together and recognize that we've got to do it as a state and in collaboration. Bruce's point is well taken, and I want to try to give you a little background on how this works. I'll try to do it in lay language. I think the biggest problem is that the rising cost of healthcare is disconnected from the resources that are available to pay for it. So consider this: healthcare is perhaps the only business sector that produces goods and services that none of its customers can afford. I mean, what else works like that? The only way this works is that the cost of healthcare for individuals is heavily subsidized increasingly with public resources, right? So those resources are either provided directly through programs like Medicaid and Medicare, or indirectly through the premium subsidies in the Affordable Care Act market, or through what's called the tax exclusion for employer-sponsored coverage, which exempts the cost that employers pay for premiums from federal income and payroll taxes. So as a result, almost all of us, the vast majority of us, depend on some kind of public subsidy. It's not just people on Medicaid, it's all of us, to make their health care affordable. So as Bruce said, if you're on Medicaid, the subsidy comes from the state and the federal government. If you're in the Affordable Care Act market, it comes from the federal government. If you have workplace-based coverage, it comes from your employer and the federal government. And if you're on Medicaid, it comes from the federal government. So the point is that the only way our healthcare system works the only way the economics of practicing medicine or running a hospital works is as long as those public and private payers, the state, the federal government, and employers are willing and able to continue to pay those subsidies. But as the cost of health care has increased, both public and private payers have developed ways to protect themselves from the cost shift, not by trying to reduce the cost of care, but by shifting it somewhere else. So let's start with public payers, the state and the federal government. They both shift costs. They do it differently depending on whether or not they have to operate on a balanced budget. States are constitutionally required to operate on a balanced budget, right? And so that means that as healthcare costs go up, they compete directly with investments in education and housing and a whole host of other things, many of which have a far greater impact on the health of the population than simply access to medical care. At some point, they're forced to shift costs to individuals by changing eligibility for Medicaid or other state-run programs to drop people from coverage. As Bruce just indicated, there's likelihood if nothing changes, and I refuse to accept this outcome, if nothing changes, probably 200,000 Oregonians will lose their health coverage, all right? The federal government doesn't have to balance the budget. And so what they've been doing, Congress has been doing, both Democrats and Republicans, I would add, are pushing the cost of Medicare and Medicaid and the tax exclusion into a national debt that is now $38 trillion and leaving the bill for our children and grandchildren to pay. Now, I leave it to you to determine whether that is a morally defensible or economically sustainable policy. Now, private payers, employers, essentially what happens is as the cost of health care continues to go up, as the number of uninsured people increases, and as the lower reimbursement in Medicare and Medicaid, which I think Bruce is going to talk about, erodes margins, those costs are shifted to employers to increase premiums, right? What the employers do is they shift those back to their employees by increased co-payments and deductibles, often to the point that those people, for all practical purposes, are uninsured, right? So cost shifting is a direct response to the total cost of care, and paradoxically, the cost shift creates a vicious cycle that drives a steady increase in the number of uninsured and underinsured people who can't afford the cost of care. And it's just this vicious cycle. So my point is that simply spending more money on the current system actually makes it worse, not better. This is a structural problem. It's not just a funding problems. So I think the takeaway is that just wishing we had more money, even if we had more money, will not assure access, and it will not, in fact, provide long-term stability for the players in the system. I'm still on.
Okay. One thing I forgot to mention was the third big blow, which is not directly related to HR 1, but the fact that Congress failed to extend the tax credits in the ACA individual market. What that's going to mean is about 10 to 15% of Oregonians are dropping coverage because it's too expensive. So yet another issue. But let me just first talk about what we'd like to do over the next few minutes is talk about both short and long-term fixes. Let me talk about some very short, immediate fixes that we're going to need to do. You know, one, in this environment of HR 1, we've got to assure that as many people as possible don't lose coverage. So what can we do to make certain 200,000 people don't lose coverage? Well, we can create simple systems to be able to help people meet the requirements. We can work with community partners and others to be certain that everybody really understands what's at stake, that there's technical assistance, and that we make it a statewide effort to be certain that no one drops off because A, they didn't fill out a form correctly, or B, something went to a different home, or quite frankly, they just didn't understand the complexities of filling out some of these applications, which are mind-boggling. So that's one that's important. Number two, we've got to preserve our capacity to deliver care. You know, coverage doesn't work unless you also have access to services. So that means being certain that we support healthcare providers, and particularly those that take care of vulnerable populations around the state. What does that look like? Well, a couple things. One, let's decrease administrative burden. I'll talk more about that in a little while. But we've got to really pull providers away from administration to be able to put them into the delivery of services. Healthcare has become just way too complex, and we can do something about that. You know, secondly, we need to, provide some financial support to some vulnerable providers. What does that look like? Well, just recently, Governor Kotek fought for getting $25 million to preserve labor and delivery services around the state to help shore up those rural hospitals and providers that are at risk for going under given the financial uncertainties of the future. So we need to do that. And I think lastly, we need to spend really special attention to our particularly vulnerable populations. Everyone on the Oregon Health Plan by definition is vulnerable because they're low income. But indeed, those with serious persistent mental illness, pregnant women, those who are in long-term care, those with multiple chronic diseases are particularly vulnerable. We need to figure out how to craft an ability to respond to this that isn't one size fits all. We need to focus it on specific populations, rural, urban, different ethnic and minority populations. We need to have a clear, consistent message, and we need to be certain people don't lose coverage. That's going to be clearly important. I know Governor Kitzhaber has some other short-term fixes that we need as well.
Yeah, I think we're in the cone of silence. Apparently, is that working? This working?
Now we're
The magic touch. That's why you still have a license and I don't.
my kids don't trust me with medical care, so there you have it.
My kids don't trust me. Let's talk a little bit about short-term fixes. What we face in the short term is essentially a math problem. How do we reconcile rising costs with diminishing resources, right? And since, as we discussed, Oregon has to operate on a balanced budget, there are really only 4 choices. These are not unlimited. There are only 4 choices. You can cut what you pay providers to take care of people who are on Medicaid. You can cut benefits. You can cut eligibility, or you can reduce the total cost of care. That's it. So I want to, before I go on into each one of those, I want to just tell you why I think our Medicaid program, at least a number of years ago, was quite a bit different than those that are operated in other states. So in 2011, right when I was beginning my 3rd term and Bruce was running the Oregon Health Authority, we had a $3.5 billion revenue shortfall, and about 1.2 of that was in Medicaid. So we decided we'd try to redesign the care model to see whether we could get something that got us better value for each dollar spent. So we created something called Coordinated Care Organizations, or CCOs. So before that, the Medicaid was provided through what's called a fee-for-service payment model, where a physician gets a fee for every service or procedure they do, right? So the more you do, the more you get. And because those fees aren't necessarily associated with health outcomes, the incentives are aligned to maximize revenue, not necessarily maximize health. Our coordinated care organizations, at least as they were originally envisioned, operated on a global budget. So they got a fixed amount for each individual who was enrolled, and they had to meet quality and outcome metrics within that budget. And the original coordinated care organizations had a growth rate, an annual growth rate that was 2% below medical inflation. It wasn't 3.4%, which is, I think, the general attitude today. We'll come back to that. That's really important. So we basically changed the incentives. So now let's return to those 4 areas. So the first option is to cut reimbursement. The problem is, if we cut reimbursement much more in the CCOs, they're not going to be able to operate because the rates that they're being paid are below the medical trend. And that's due in part to the fact that actuaries in the Oregon Health Authority, I think, have not fully accounted for the overall growth of medical costs when they develop rates for CCOs. So if you cut those any further, what's going to happen is CCOs are going to refuse to contract with the state, which already happened in Eugene earlier this year, which will throw the whole system back to fee-for-service with no constraints on utilization, no constraints on costs. A very bad outcome for the state of Oregon. So that leaves eligibility and benefit. In my view, and I think it's reflective of what Bruce said, in my view, the highest priority of the state to make sure everybody has some coverage, at least in the short term, even if that means in the short term some modification of the benefit or designing different benefits for different populations. We have a huge crisis coming down the road, and we've got to be very creative in terms of making sure people have access to good primary care and some kind of catastrophic backup at the very least. Fortunately, Oregon remains the only state in the nation that has a transparent, public, evidence-based process in which we can have the debate, public debate, about the difficult and inevitable trade-offs we're going to have to make over the next few years between coverage and benefit. And I think that this state should be fighting to preserve that structure, and I think we should be doing everything we can to extract more flexibility out of the federal government in order to manage through this crisis. They took the money away. They need to give us the tools to manage it in a way that fulfills our responsibilities to the health of Oregonians. That brings us to the fourth option. The only way in the long run that we can avoid difficult trade-offs between coverage and benefit is to reduce the total cost of care. And that, to me, is the real challenge here and the real opportunity.
So before we talk about how we reduce the total cost of care, I just want to spend a minute talking about the structure of our current healthcare system, because putting more money into our healthcare system, quite frankly, is not going to work, because we have a structurally broken healthcare system. And it's broken in a variety of ways, and let's go through each one of them. First of all, how we pay for care is socially unjust and administratively complex. Think about it for a moment. 3 people walk down the street. They all fall in the same hole, break the same leg, go to the same hospital, get the same x-ray, get the same cast, and are put on their way. Depending on their health insurance, that hospital's paid 3 different rates, depending on whether they're Medicare, Medicaid, or commercially insured. The Medicaid pays the least. Medicare, not so much, a little bit better. And then there's commercial insurance. Think about that for a second. We have a healthcare system that pays doctors and hospitals less to take care of the poor and the elderly and more to take care of the commercially insured. And you know something? We just accept that. That's morally bankrupt, and it makes it incredibly complex to be able to, for individuals to deliver care. So we have a totally broken payment system that we've got to address. That's number one. Number two, we have a healthcare system that focuses on disease instead of health. And we've got to flip that around. So think for a moment. Our hospitals, to stay afloat, need to continue to fill their beds. If you had an appropriately working healthcare system, you'd actually want to decrease the number of people who need to rely on hospitals for care. But yet, our incentives are backwards, and we incent disease, and we don't incent health. And we incent taking care of one group as opposed to another. And I'm not criticizing our healthcare system. They're just reacting to the realities of the financial incentives that are out there. 3, quality is incredibly uneven in our healthcare system. Any measure of quality looks like a scattergram. We have qualities all over the board. Why is that? Well, it's because of the fourth thing. Our system is so administratively complex. Why? Imagine any sort of medical practice, hospital, clinic, any clinical provider may have contracts with 20, 25, 30 different insurers and payers. And each one of those insurers and payers has a different standard for quality, has a different way that they want that office or that hospital to deliver care. So imagine trying to figure out what's the best way to do things when you've got 25 different people telling you 30 different ways to do things? No, we don't have a clear sense of direction and of policy. And because of that, our system is way too complex, and we don't get the outcomes that we want because we don't have a consistent way to do that. What we'd like to do appropriately would be to move everybody who has getting low value, high cost care into getting high value, low cost care. But when you've got 25 different contracts, that's really hard to do. And then lastly, it's just way too expensive. And the governor will talk about this in a second, but healthcare has become unaffordable for states, individuals. We keep shifting costs on to people. You may be insured, but if you're a $50,000 a year wage earner and you have a $10,000 deductible health plan, that doesn't help. States can't afford it. The federal government can't afford it. Businesses can no longer afford it, and individuals can't afford it. Number one cause of personal bankruptcy in the U.S. is healthcare debt. But the next piece always blows my mind. Of those people, many are insured. So imagine that for a second. Individuals with insurance who are going bankrupt because of healthcare debt. They're paying their premium every month, and then they have some catastrophic problem, have a $10,000 bill, and it's unaffordable. So we have a structurally complex, morally bankrupt healthcare system that's way too expensive, and just putting more money into it is not going to be the answer. So one of the things we need to do is focus on how do we get at that total cost of care. Governor?
Yeah, thanks, Bruce. So I think I'm going to touch on a couple of short-term steps, but it's really important that we don't be reactive in how we address this. The short-term steps can't be one-offs. They have to be aligned with the longer-term strategy, right? And I'll come back to that in just a second. I think one of the things Bruce mentioned is we could reduce the mind-bogglingly complex administrating and reporting requirements that don't add a lot of value but take time, energy, and resources away from direct patient care. Our CCOs each year are required to report on almost 150 different pieces of data each year. I mean, it's mind-boggling. That's one. The second one is, as I discussed before, I think we need to think about the possibility of assigning different benefit packages for different populations based on what we think their health needs are likely to be. I think we have to revisit what the core mission and what the core population of our Medicaid program is going to be. And I know we can come back to this one later in the day. I think we need to also reevaluate the role of coordinated care organizations in providing social services. It's not that we don't need those services, but is the healthcare system the best place for that to happen? We should have a conversation about that. But to Bruce's point, it is essential that we stabilize the Medicaid program. First, because it provides access to care for some of the most vulnerable people in our state. And secondly, because what happens in Medicaid has a huge impact through the cost shift on the commercial market and ultimately what are paid by employers and employees. So let me just wrap up with a longer-term perspective. First, we need to remember that the crisis we're facing today wasn't created overnight. It was created over decades, which means you can't fix it in one biennium. It's going to take, I would say, at least 3. That means we're going to have to figure out how to be able to align individual policy and budget decisions over 5 or 6 years, maybe different legislative makeups, maybe different governors, to make sure that we're moving forward. I think that requires that we adopt a very clear long-term vision for what we want our healthcare system to look like in, let's say, 2033. The values we want it to reflect, the outcomes we want it to produce, and like a North Star, right? So we actually have a joint concurrent resolution in this session of the legislature we're trying to pass, hopefully with broad bipartisan support. It's House Concurrent Resolution 202. It's in the House Rules Committee. We're hoping that can serve kind of as the benchmark. The reasons that is important is because you have to be able to evaluate those individual decisions over the course of 3 biennia to make sure they're moving us towards or away from that long-term goal that we want for our state. As I mentioned earlier, there are multiple factors and multiple parties who are all contributing in one way or another to the cost shift and driving up the total cost of care. One of them is the fact that Bruce mentioned that a very high percentage of Oregonians are on either Medicare or Medicaid, which pay significantly less than commercial rates, and that's part of what's driving the cost shift. I want to just quickly list a few more that I think should all be on the table. One is our poor business climate. Does have effect on some of our largest businesses, which in fact are hospitals and health systems. The one we already mentioned, costly, burdensome regulatory and reporting framework. We've underinvested in our primary care system, which is critical to manage care and manage cost. We have some inefficiencies and misaligned incentives in both our delivery and payment model that we need to look at. We have to address the disparity between unlimited demand and finite public resources. That gets to some of the most difficult conversations, but we have to have that conversation. It's going to happen explicitly or implicitly, and we should do it explicitly like we always have those conversations and try to get the greatest benefit for the greatest number of people with the resources that we have for that purpose. And then there's some external cost drivers that we don't talk about very much. The cost of prescription drugs, the cost of labor, other workforce issues, and also a broken, fragmented behavioral health system. The point is that there's no single cause to solve the healthcare system. It's a very complicated system, as Bruce described. I believe that Oregonians are perfectly capable of managing through this complexity and producing a system and use this as an opportunity to produce a system that's effective, that is equitable and sustainable. The biggest obstacle to that is ourselves. We're the biggest problem. And what do I mean by that? I mean that for decades, insurers, providers, labor, employers, and consumers have been pointing fingers at each other and blaming each other for the total cost of care, right? And they have resisted and sometimes outright refused to sit down together and work together to create a strategy that can move us towards the kind of system change that we need. If we continue to operate in those silos, if we continue to ignore the fact that we're all part of the same failing system, and every one of us in some way is going to be damaged if we don't change the trajectory of our healthcare system, we're going to continue to perpetuate what I call a zero-sum politics of scarcity that produces winners and losers but can't produce a lasting solution. I think the opportunity here in this moment is for Oregonians to rise above and beyond the partisanship and the divisiveness that is now the hallmark of politics in America and come together as Oregonians who are facing a common challenge. And hopefully as we do that, we might also begin to repair the fabric of our community here in this state. Thank you.
So we're ready for questions. And I know some of you sent in questions. We did not read them. So, no, I say that so, you know, I hopefully we can have a dialogue and a conversation, and you're not going to get canned responses.
So if you have a question, please feel free to line up. And again, 30 seconds max. I will be holding the microphone. Sorry, I'm not giving it away. And please do end it with a question mark.
Danelle Stevens, City Club member. Every fall, I receive a newsletter with the ridiculous packages of choices for Medicare. Pages and pages. I'm sure you all know what that is. And I think, as you said, we need a reframing of healthcare as insurance, like car insurance, that everyone pays, and everyone has to pay thousands and thousands of dollars for years and years and years and get nothing back. I mean, if you don't have an accident. Okay, I appreciate your clear thinking, refreshing, and honest evaluation of this system. Thank you. And so what is the first big step we need to take to move toward healthcare for all, similar to Canada or Great Britain?
So I think the first step, this is just me speaking, I think the first step you have to do is normalize payment. I think payment really drives things, and I think the second thing you need to do, or the thing concurrently with that, is more about vision in politics. I think you have to create a vision of where we need to move, and because this is as much a policy as it is a political issue. I don't know, John?
Yeah, I agree. I mean, the disparity between payment for different, for commercial and even within the commercial market, it makes absolutely no sense. Right. So I do think normalizing payment it's not easy, but it definitely needs to be high on the list of things to do. I also think, we're actually moving towards a publicly financed system incrementally. I mean, if you look at the subsidies I mentioned, the Medicare, Medicaid, the tax exclusion, we're moving in that direction. But I do think that at the end of the day, as Bruce said, we have to have a collective vision of what we want this healthcare system. I'm going to, real quickly, I'm just going to give you an analogy. If we don't know where we want to go, there's no way to get there. And some of you I know are old enough to remember Kennedy's speech in '62 about going to the moon. He did not give us a roadmap. He gave us a destination that we all wanted to do. What we need is that same thing for healthcare, and change the debate from where we want to go to working through the politics and the trade-offs on the path to get there. We have to get those explicit and on the table.
30 seconds. Huh? Yeah. Oh. Hey, Valdez Bravo, thank you so much for this. President, Healthcare for All Oregon. And just to stay on the analogy, Governor, I do feel like, Oregon is well suited to tackle this problem, more so than other states, because we have had the Joint Task Force on Universal Health Care that studied the issue and the attitudes of Oregonians for 3 years. And now we have the Universal Health Plan Governance Board, which has been meeting since February 24 and is scheduled to come up with recommendations for a universal health plan in September or slightly thereafter. But that's my question. If you could just touch on the work of the Governance Board, because I feel like to the NASA moonshot analogy, we have mission control. It's the Universal Health Plan Governance Board with their Finance and Revenue Committee, operations, community engagement, plan design, and I feel like they're really shaping that true north and frankly the blueprints. I think we just have to rally behind that. If you could touch on that.
Well, Bruce was honored at one time, but I'll kick it back to him after this. I'm very familiar. I've spoken to the Governance Board, and actually the chair of the Governance Board is on this group that has been trying to develop some recommendations to the governor on long-term sustainability of the entire system. It's not a concern. I think it's as we move in that direction. I think it's very, very important to start with the outcome, not the parameters. So I understand that there is some directive that we want to have a single-payer system as a part of this. Well, a single-payer system, I have nothing wrong with a single-payer system. It's a way to pay for something. If we don't change what we're buying and how we deliver it, we haven't actually solved the problem. So I think getting sort of describing in a little bit more granular way what we want that system to look like. What are the values we want it to reflect? What are the principles of equity that we want built into it? How about accessibility and the difference between coverage and access? And then walk back from that. And then that's really have to do with the political trade-offs. You will probably have the insurance industry not too delighted. The insurance industry as it's structured today, maybe it gets changed a little bit, right? But I do think you have to differentiate between where you want to go and how you get there, because how you get there is where the politics happen.
And full disclosure, I chaired the task force and am on the governing board. And, I think that what's being laid out is a blueprint for addressing a lot of the changes that we've talked about today. I think the challenge, apropos of the previous question about what do you do, is how you garner public support, how you articulate some of this, and how I think many of us have just become sort of, I think, numb to our current healthcare system and overwhelmed by it. And it seems overwhelming and difficult. And I think what we need to do is, whether it's a North Star or blueprint or whatever you call it, we need to have a vision that we all can wrap our heads around. I think that the governance board is providing that.
Richard Gibson, Universal Health Plan Governance Board, Finance and Revenue Committee. The literature has shown that effective access to primary care avoids greater downstream costs. Is there an opportunity in Oregon to raise the rate of primary care payments for Medicaid, draw down more federal funding for that, and that set a baseline such that Oregon becomes a great place for primary care? We raise the primary care workforce, and we help avoid downstream costs in the health system. Could Oregon do that even absent the Universal Health Plan in the next several years? Thank you.
Yeah, I think definitely. In fact, the group that it's called the Healthcare Sustainability Group, has a number of primary care docs on it. And I do think we have to think how we redesign how we finance and pay for primary care. For example, a lot of things that require prior authorization, maybe you waive some of those for a big chunk of what primary care providers have. But I think that's incredibly important to get that primary care infrastructure in place.
I think the issue is in this current fiscal climate, how you find the dollars to do that. And I would say this gets at the larger system, which is how do we start to devise a system that actually is based on primary care and prevention as opposed to the system we have today. I think that supporting primary care with additional dollars makes a lot of sense. But I think the issue is how do we create a larger that's not an endpoint. That's actually a finger in the hole of our healthcare system. We've got to actually think more broadly about that.
You know, Richard, I think one other aspect of this, and this is true, we don't do prevention very well in this society and here, but we're going to have to collectively say there's some things we're just not going to do this biennium. We're going to do this because it'll reduce costs downstream. If we don't do anything to change the healthcare system, it is going to literally eat up the entire general fund budget. And $38 trillion is actually a pretty big number. Someone's going to have to pay that at some point in time. So I do think that's why we have to have some clarity about where we want to be next year, the year after that, the year after that, so that it'll help make those kinds of short-term investments that can reduce the cost long-term.
I'm Howard Klenk. I'm the vice chair of the Oregon Health Forum Lund Report Board of Directors. I'd like to move us, we encourage you all to subscribe, just as a plug there for a minute. I'd like to move us from the intermediate and long term to the dumpster fire that we're currently in the middle of. And when you guys used to rule the world, if you did now, or at least our part of the world, if you were to direct the legislature, the Department of Human Services, the OHA, to come up with a plan to, as close as possible, Trump-proof the Oregon healthcare system for the immediate future, what would the specific steps that you would ask them to do be?
Well, I'm not in politics anymore, so I can say whatever the hell I want, right? This may sound silly to you, but I do think it requires a convening of the key players that are necessary to make this happen. Oregon is still a state, I believe this, I used to believe it, I still believe it, where you can probably count on two hands the number of people that have to say yes to get something done. They don't ever talk to each other, right? And let me give you an analogy. When we did the Oregon Health Plan, probably a lot of you don't remember that, but this was viewed nationally as a rationing plan. I mean, it was incredibly controversial. We had a table that had hospitals, doctors, insurers, labor, consumers, and the rules were, we adopted a set of principles about what we wanted the Medicaid program to do. And only way you could be at the table is if someone put something on the table, a proposal that someone didn't like. You couldn't just say no. You had to say, well, here's two other options that will still meet the principles that work better for me. And you can almost feel the moment at which you break the trust barrier and people go, oh my God, we're doing something that could really be big. And then things become easier. So I do think getting the key players at the table is just absolutely incredible. I mean, that's the policy. I don't think we don't. The second thing is it's not clear that we have a long-term vision for where we want our healthcare system to be in Oregon in 6 years, and we really do have to have that.
Let me just a couple thoughts about how to deal with today and the dumpster fire. First off, Howard, I wish I had had the power to direct somebody. I neither directed the governor nor the legislature. But having said that, one, I think it's going to be hard to distance ourselves from federal policy. But I think what we can do is some of the things I just spoke about. Is we can, during this next period, certainly be certain no one loses coverage. I think that's critical, and should be a firewall for us. Is we've done an amazing job as a state of insuring about 97% of us, and that should be our firewall. How do we hold tight to that during this current administration? That's number one. Number two, we're actually doing. Governor Kotek has put together a group to start to look at how we can get some greater savings and efficiencies in our system to be able to stave off some of the budget cuts, because as Governor Kitzhaber enumerated, we don't want to cut people off. We don't want to reduce what we pay for care. We want to continue to be able to provide that. So we've got to look long and hard at where and how we can make some of the changes to deal with losing, I'll say it again, next biennium, $3.3 billion. I mean, that's just an enormous loss to our healthcare system, and it's really, really sobering.
Let me just add one point to that. I am an eternal optimist. I don't believe that ultimately over the next 6 years we're going to lose that much. I think the impact this is going to have, particularly on red states, is going to be mind-boggling, because they're very rural and they have a high percentage of Medicaid. The worst thing that could happen to us is have some of this money restored and spend it right back on the old system. We cannot do that. We have to have by 2 years from now, need to think through, if we had more money, where would we spend it and how would we spend it? What would we stop doing? What would we start doing, right? And I think that conversation, we're good at it in Oregon. It's a big state full of smart people. We need to engage them in sorting that out so we're ready.
That's the key. I mean, again, a crisis is a terrible thing to waste. So how do we start? The changes we make now to address that need to be linked to a further vision of where we want to go.
Wow. Hi, I'm Colin Stackhouse. I work with Healthcare for All Oregon, and I'm a member of the Universal Health Plan Governance Board's Community Engagement and Communications Committee. And so my question obviously is back to the governance board. Bruce, you're delivering that plan back to our Oregon legislature this September, and we can predict that the legislature will refer it to voters for the 2028 election. And the timeline that's been floated is around 2032 for us to get the federal waivers that we need to implement the first single payer or close to it system in the country. So a lot of work to get to the end result, but to a degree, I think it's an inevitability because our system's broken and we're tired of it. So what can the gathered healthcare professionals in this room do to try to wrap their heads around this public reckoning that's potentially coming in 2028 and also this real potential transition by 2032?
I think it's, as we've said a couple times, it's about being able to rally around a common vision and a sense of where we need to go. And I don't take that very lightly. I think being able to have a common direction and a common vision and a common sense of how we get there is going to be critical. So I think, in the end, it's not simply a policy issue. In fact, it's rarely a policy issue. It's more about politics and communication. And that's key. And I think sometimes what we do is just focus on, well, this is the right thing to do. And I'm not sure that that's a sufficient answer to a lot of people. You've got to be able to garner a broad coalition from across the state that actually won't want this to happen. So the plan and the report are actually the easy step. The hard step is, how do you be certain that people from Pendleton to Portland and, from Bend down to Ashland actually understand and can communicate that? One of the, when we did the health reforms back in 2010, 2012 that the governor was referring to, it was a lot about garnering public support. There was a day when we knew we had been successful, and there was a health policy conference here in Portland, and there were some folks from out of town, and they told this story that they got into a cab, and the cab driver was asking them, "Oh, what are you doing in town?" They said, "Oh, we're in this, we're at this health policy conference." And the cab driver said to them, "Well, have you guys heard about Oregon's health reforms?" And it was at that moment that we realized, okay, we've passed a milestone. People are starting to understand, and I think that's a big piece of this, and not to be underestimated.
Hello, Dr. Goldblatt. Hello, Dr. Kitzhaber. I'm wondering, I work at Multnomah County. My name is Lisa Rose Gagnon, and I do cross-sector integration work for the Homeless Services Department. One thing that we see that is incredibly challenging is getting folks engaged in services. It is incredibly hard to get in contact with the folks that we serve, don't have phones or addresses often to stay in contact. With the current recertification process for OHP, that is still a barrier and an issue. I am terrified for what is going to happen with the increase in recertifications and the employment requirements. I know there's a lot of other populations as well that will be impacted by this. I'm wondering if you know of any efforts that are currently going on a local and state level to try to address these concerns, and if not, what would you recommend for us who are doing this work locally and at a state level?
First off, Lisa's a recent graduate of our great OHSU PSU public health program. We're creating great students. I'm unaware of what's being done, but I think your question is great, because it's about the complexity of our system, and it's not just about getting care. It's just in so many places being able to get through all these administrative barriers. It's key. I don't know what we're doing, but I can tell you that we need to. When I was at the health authority, we had a 17-page application for the Oregon Health Plan. Can you imagine? And we were charged with getting it down to 2 pages. We finally did 2 pages plus a signature page. We couldn't get that last signature piece, but it's terrible. It's a terrible situation, and we've got to do something about. It isn't just a complexity when you're in the system. It's being able to get in the door. I mean, think about for a minute our Medicare system. You turn 65, what happens? You're on Medicare. You actually don't have to, it's not all of Medicare, it's Part A, but you don't have to fill out an application. You don't have to do anything. You turn 65 and you currently have coverage. We got to think about new ways and different ways to be able to get people into getting care, but I don't know of anything that's going on right now.
Just a quick example, we spent the last year with an organization called the Oregon Health Education Collaborative trying to develop local community-led delivery models for services to pregnant women from conception to the first 1,000 days. What we learned is that you actually have to create the delivery system in the community. A lot of people don't trust the state agencies, which is not fair, but they don't. It's incredibly complicated. But there may be some work there you could take a look at, because we engaged 5 different communities, including Eastern Oregon, Southern Oregon, and in the Willamette Valley. I would recommend a book by Jennifer Palco called Recoding America if you haven't read it, because it talks about, it basically talks about the bureaucratic, it's not the fault of people who work in the agencies, it is the structure of the system that's grown over the years. You see it with the health authority, with regulations. Nothing's taken away, they keep being added. And so I do think that, thank you for putting that on the table, because this is not a funding problem. This is a delivery problem, working through the dollars to actually make sure they get to the people that actually need them. That's really important for us to put in the mix here.
Okay. Hi, my name is Crystal Otero. I also work at the Homeless Services Department in Multnomah County. So when the Metro Supportive House, this question is about like, where are the cheapest investments for housing for our most like high utilizers, as it sometimes people are described, right? So at OHSU, there's a list of 100 people who go there, who've been there 100 times in a year, for example. And typically they have persistent mental illness and are homeless, chronically homeless. So thinking about that population, when we receive the Metro Supportive Housing Services, or SHS tax dollars, we invested in a kind of pilot where we paid for 150 housing vouchers for anyone that was on ACT or ICM. And what we found is over the last 3 years, they have like a 95% retention rate. Because the ACT and ICM, which is the Medicaid funding for services, they visit their person every week. And so that type of intensive case management really supports the person to stay in housing. And I've been thinking about it because the investment to house the investment to pay for 150 housing vouchers, which is 150 families, right? It's a lot of single families or single, one person, but there's also, anyways, so basically what I'm trying to say is it costs about $3 million a year for 150 housing vouchers for really people who can be high utilizers and cost a lot of money. And what I've been wondering is, why can't we as a state say, for example, anyone that's discharging from the Oregon State Hospital who's going to have intensive case management automatically has a housing voucher? Why can't we say that? Or can we say that?
Your point is really well taken, and it's a couple-fold. One is, unfortunately, sometimes our inability to prioritize things. In my experience, we're very gracious as Oregonians, and what we want to do is support everyone and everything. And that's a great example of the fact that we're spending tens of millions of dollars on having people in acute care hospitals and having a host of costs in our healthcare system because we're not prioritizing making some investments in housing for those who need it the most. So I think I think your point is really well made, and I think, to me, an effective system is one where we look across a community and understand what the needs are and invest in them.
Yeah, I think this gets back to sort of, I call it the front end, back end problem. Eric will correct me, but these numbers are approximate, but I think it's something like 55% or 10% of the population in health share is driving like half the hospital admissions and half the costs and half the ER visits. It doesn't make a lot of sense. We know who they are. They come into the hospital, not really for their addiction problems, but for upper respiratory infections or wound care, et cetera. Then they go right back to the same environment, and they recycle through. It would take an initial upfront investment, And there are models that have been in other states, New York, for example, that actually can get at this, but you have to spend money on the front end, which means there's something else you can't spend money on. And I think that's what Bruce is talking about with prioritization. And the reason, if we can have a clear, robust vision of what we want our outcomes to be in the long run, it gives you at least a context in a tight budget to say, well, we'd like to do this, but if we don't do this, it's going to cost us more later. We don't do that very well, but I do think that having that destination that people can see and feel gives us a better chance in the budget process to make those kinds of early investments.
Hey, my name is Bennett Garner. I'm the co-chair of the Oregon Psychiatric Physicians Association Legislative Committee. And one of our goals is to be part of the solution with regard to maintaining Medicaid enrollment. NAMI and the Legal Action Center issued a document that seems to suggest, well, it doesn't say, it states that individuals can self-attest that they have a substance use disorder or a mental health problem, and they're exempt from the work requirements. So one of my questions is, do you have any details about that? And the second is, any suggestions how to involve providers who are actually seeing these individuals that are going to fall off the rolls to help maintain their enrollment in Medicaid?
Great issue. One, unfortunately, no, I have no further information, but let's connect afterwards and I can connect you with someone who does. On the second question, this is really about, I think, and there are people working on this right now at the state, is being certain that we provide the kind of technical assistance across the board to everybody, so that, quite frankly, every psychiatrist knows what the rules are, how to get people attested or whatever needs to happen to have them exempt from the requirements, because indeed there are going to be some specific ways that people can get exempted, and this really becomes one of how do you provide technical assistance and how do we assure that, in 6 months every psychiatrist can raise their hand and say, we know how to do this.
Hi, my name is Charles Gallia, and it's quite an honor to be in front of my two former bosses. I want to first thank you both for being steadfast supporters and having expression of faith in Oregonians to be able to address the issues that are in front of us. That says a lot, but you also have the reason to show that it's working. My question is kind of complicated, as you might imagine. One of it is that I heard you say that the CCOs ought not be involved in the social determinants of health, and I was wondering, we aren't funded in a collaborative structure at the state level. We don't have the mechanisms to address those anyway, and so how is it supposed to work? And then the second question is, I have deep concerns about retrenching from our emphasis on preventive services and early childhood work, because that's easy to do, because you're gonna, the system has a tendency to respond to the things that are right in front of it. And how do we avoid making the poor choice of disinvesting in preventive services, particularly for kids?
Well, the first statement, I want to make it clear that I mean, those questions are a little bit related, because it's clear to me that, we spend 70% of our general fund is spent on medical care and education. And most of people's lives are not spent in school, including kids, about 7 hours, they're like 7 hours a day. That means 17 hours a day they're somewhere else, and most people aren't in the clinic. But what happens when they're not in the medical system or the educational system has everything to do with their health and their ability to learn. That's why those front-end investments are so incredibly important. My only concern with the CCOs post HR1 is the reason the CCOs are providing what's called health-related social needs, housing and nutrition, is not because they're important, not because we sat there and said, let's see, where's the best system to deliver those services? Oh, it's the healthcare system. We did it because there were Medicaid dollars. CCOs are not housing authorities, they're not social service agencies. they're not school boards. That's not their core competence. All I'm suggesting is that with $8 billion coming at us, maybe what we should do is really try to focus them on clinical care, on health care, and figure out a different place. So it's not an either or. You have to do both. Right? And I think that the problem with early investments in kids, I've been doing this since 2020 and haven't much to show for it. Kids are really invisible. We talk about putting kids first, but in the legislative budget process, they are an afterthought, and they're really cheap and they're really invisible until they're not. And then we pay the cost the rest of our lives in lost productivity and just human suffering that's all avoidable. So I don't know how we make that point, but I think that ought to be one of the principles in our long-term vision, that we're going to do everything we can to keep people out of the acute care medical system as a fundamental principle.
Hi there, my name is Abigail Mavity. I'm a current student at the OHSU and PSU School of Public Health at the very tail end of my master's in public health. My question is about motivation. For myself, my peers and my colleagues, and I'm sure everybody else in this room, you mentioned earlier feeling numb to our current health system and all the issues that we've discussed today. I'm asking for younger folks who are entering the field of public health and for folks who are just now entering the field and getting their career started, with all of the disparaging news that we get every day, do you have any advice to keep folks going that you would like to share?
You know, I actually think about this a lot, and I vacillate between, being depressed and down about current things, and then looking for the opportunities. And I don't know whether this gets at it directly, but I've come to, I think, believe that the best thing we can all do is present an opportunity of hope and of opportunity. That doesn't mean we should be Pollyannish and ignore what's going on, but I get concerned when I think about my own children and grandchildren that all I'm doing, if all I do is complain, that's not a legacy that I want to leave for them. I want to leave a vision. So I think my advice is, how do we all focus on what we can do and how we can do it?
Yeah, I think what we have to do is we have to do everything we can to engage young people like you in this process. And I call it thinking like a salmon. Over the course of my years in public service, I have had a lot of frustration. The Archimedes movement didn't go where we wanted to go. The upstream initiative didn't. But if you think like a salmon, they know where they want to go. They want to end up on the gravel, on the gravel bed where they were born. And to them, successes are they a little bit further upstream this morning than they were yesterday morning. So I do think that if you need a vision, you need to be inspired. But I think little things that you do, set the goals, right? You're not going to get there overnight. Sometimes you won't get there in your lifetime. But having little short-term victories that you can count and that can keep you motivated, I think is incredibly important, because this isn't going to happen overnight. It's going to happen small increments by people of courage and conviction that are taking actions every day. And thank you for what you're doing.
And have events like this where there's a different demographic in the room.
Yeah.
And I don't mean that critically. I about anybody or anything. I probably shouldn't have said that, but I'll just be quiet.
I will take this opportunity to plug April 1. There will be a happy hour co-hosted by the new Leaders Council of the Portland City Club talking about healthcare policy. Thank you, Governor Kitzhaber, for agreeing to attend that. Next question.
Hi, my name is Marissa Cade, and I just wanted to, I'm grateful to be in Oregon, and we here in Oregon have the Healthier Oregon program, where we extend OHP coverage to families in Oregon regardless of their immigration status. And my question is, because the Healthier Oregon program is primarily funded by the general fund here in Oregon, although not entirely, which creates some challenges, how we might be able to think creatively and work together with the advocates and lived community folks who utilize that program across the state to think about reimagining how we're doing this, how we're doing Medicaid and the Oregon Health Plan in Oregon. And what would you recommend in terms of how we protect and focus on that program and also use it to have conversations about what's possible for the future of healthcare here in Oregon?
Well, I mean, I mentioned one, and none of this is easy. I mean, I do think that's a population where we could rethink the benefit. I don't mean making a skinny benefit. Maybe we make sure that everyone has access to a really good primary care network, a patient-centered primary care home, and that they have some kind of catastrophic backup. I'm just thinking we have to be able to have that conversation, because the worst thing that could happen is the general fund goes away, then the whole program goes away, right? And there's going to be a lot of pressure on that program just because there isn't the level of federal match, right? So I do think it's a conversation we have to have. That's why I said I think maintaining coverage and access is, to me, the most important priority. And we have to be a little flexible on how we do that. You know, the Medicaid benefit package is an extremely rich benefit package, and it's good. I'm glad we have it. It is probably a richer benefit package than a lot of folks in the small group market or across the state. So I just think we need to have everything on the table when we have that conversation. But the principle is we're going to keep them all covered, one way or another.
Dr. Goldberg. Hello. Is at the Medicaid table, doctor, is there conversation about, because there's statutory requirement for parity between the Healthier Oregon program and the Oregon Health Plan, and so how's that being incorporated at the Medicaid table?
It hasn't been, that hasn't been a topic of conversation.
Hi, I'm Tracy Carver. I'm the CEO at Project Access Now. Thank you both for coming and doing this session today. I think I've been thinking a lot about some of the root causes of how we got to where we are today. I'm a lifelong Oregonian, and have worked kind of public health, social services my whole career. And I think as we think about solving for the healthcare challenges and affordability components of that, I've been thinking a lot as well about what are the actual root causes of why we have so many people who are now needing to be on Medicaid, needing some of the health-related social needs services that my organization and others provide. And in this sort of space and opportunity to talk to two of you who were at one point able to really provide that direction and kind of North Star, I wonder what you see as the most important kind of tactics for us to be partnering with other sectors who also need to address the root causes of why people become houseless or are food insecure, or all the other things that we know are actually kind of underpinning a lot of where we're seeing some downstream costs in our healthcare system.
Well, you put your finger on it. I mean, to me, the root cause is an economic model that does not equitably allocate the gains in productivity. We have a growing number of people who simply cannot meet their basic needs. They wake up every morning wondering where the next meal is going to come from, and if they're going to have enough to eat and have a place to stay. They can't spend time with their children because they're working 3 or 4 jobs. And we also know that maternal stress can change the epigenetics in an unborn child and set them up for failure. That's where the ACEs come from. So I think if we're going to have a conversation, I think it's very important that the Oregon Business Plan explicitly acknowledges the fact that growing jobs or growing the GDP does not necessarily mean giving people the ability to meet their basic needs in the state. And I just think it's not pointing a finger at any sector. It's just, I think that is the root cause of a whole lot of what's going on in our country today. And I would also say that when you have a growing number of people who struggle every day in a country that's supposed to be about fairness, it creates the kinds of division and the kinds of polarization that is infecting our politics. So I think it's not just a healthcare issue, it's a health issue, and it's a stability of our society issue, and it's a social cohesion issue.
And let me just add on to that. Something, a bit more operational, which is, I think when we created CCOs back in the day, the vision was to actually create a new kind of organization that brought together healthcare and community partners and housing and all of that into a new kind of governance where this wasn't simply about creating some sort of a different managed care organization, but it was about creating a new social organization that brought together social services, human services, housing, food, and healthcare together to solve community problems locally. And the boards were supposed to reflect that. We never quite got there, but I think that's some of the ways that you start to do that is by structurally making some changes and have organizations that do look different and that do bring together all those folks instead of being siloed.
You know, and people don't remember this, but we intentionally created the early learning hubs in 2012, which is this when we created the CCOs. They were community organizations. They were supposed to be the connection between the clinical system and the non-clinical system, the upstream investments. You know, we have some that are doing that well, some that aren't, but there's no other state in the country that has that kind of, you know, almost 15 years of a community-based infrastructure and relationships. So we should rethink the ability to maybe make better connections between those early learning hubs and our CCOs, because we have the infrastructure in place.
We are at time. Are you okay on taking one last rapid fire? Okay.
Hi, I'm Matthew Breeze. I'm a family physician. This is my 20th year of practice here. And yes, Bruce, it's been that long since.
Wow.
I don't know how you still look no older, but I've been sitting here thinking about when I was in my training, there was a time of a lot of excitement. I was at OHSU and locally, and there was a lot of thinking about how do we set up primary care? What does the vision look like? And the both of you were very much responsible, I think, for that vision and that inspiration being present. But I think we've lost some of that, right? There is a sense of, where are we going? And I really am my question is, I'm very worried about the primary care workforce. Less people going in, people are retiring, people are cutting their work hours. I think it's payment, but I think it's also administrative burden and all these things. And my question is, what can we do you think, to help increase the efficacy and the size of the primary care workforce?
Let me take a cut at it, and then Bruce is probably more knowledgeable on this than I am. We are working with the Oregon chapter of family physicians with that work that they've done on sort of changes we make in the delivering the payment model, particularly a different kind of payment model for primary care, a way to reduce a lot of the administrative burden, at least for a core set of services. That will require some investment, so that's going to get us into that front end, back end problem. But I do think that that's one that is really critical. And then I think nationally, and this isn't going to be easy either, but I believe that the federal support for medical education should be based on the specialties that we need. There's no reason in the world, with a shortage of primary care all across this country, that any individual who wants to go into family practice should come out of medical school with a $400,000 debt. It's just shameful. And I think that's a prioritization issue, like Bruce saying, but I think we need to elevate that, because it's not just the work of the practice. We can probably do a lot to fix that here in Oregon, but to get that pipeline going, we need to create incentives, not disincentives, for people to go into primary care.
So let me add on to that. And I talked about the three people walking down the street who broke the same leg. Well, let's talk about the three different doctors. The primary care doctor and two specialists, and talk about 15, 20 minutes of their time. Wild disparities in what we pay people to do important work. And I'm not certain that any healthcare provider's work is any more important than another's. It's all of us. So we need to do something about payment. We need to do something about training, which Governor Kitzhaber just talked about, which is really important. I think that we can do things like there's so many public payers now, Medicare and Medicaid, we should set a new standard for primary care payment. But it isn't just simply, I think, about payment. I think Matthew, what you sort of got on is how do we recreate that spirit of innovation and can do, and how do we create that we're going to go to the moon. I think that's really important, and it gets at that sense of malaise and doldrums, and we're just here to stave off all the bad things, but we need to create that vision. We need to be able to feel like we can do this, and we will, and create that spirit. And I think it's really been missing, and we need to do something to reinvigorate that. It's great to see you.
Thank you for all those questions, and I want to give a special thanks to Dr. Sauber and Dr. Goldberg for really giving us some enlightening information about our complex healthcare system. I don't know whether to feel scared or more hopeful at this point. But I think the panel that we have coming on March 6th, right here at University Place, will help answer some of those questions. And we've got plenty from today's program to talk about. And by the way, if folks say, oh, darn, I wish I had gone and I missed that, they can see it on the City Club YouTube channel anytime following this program. And one final reminder, to learn more about City Club's programs and support our mission, become a member, visit pdxcityclub.org. And to learn more about Oregon Health Forum, visit OregonHealthForum.org. Thank you all for coming. Appreciate your attendance.